This 2022 paper, published in the European Journal of Radiology, challenges the strict foundation of how we diagnose and categorize breast cancer. Currently, the World Health Organization classifies breast cancers arising from the terminal ductal lobular units, or TDLUs, into two arbitrary buckets. They are either called ductal or lobular. This system relies on cytology. Pathologists look at the malignant cells under a microscope and assign a label based on whether those cells physically resemble normal duct cells or normal lobule cells, rather than identifying the actual anatomical site where the cancer started. Because a cell happens to look like it belongs in a duct does not mean it originated there. Grouping cancers by cellular resemblance confuses a loose visual association with actual biological causation. When medical professionals rely on inaccurate names, it impairs their ability to predict patient outcomes and design precise clinical treatment plans. To fix this, breast cancer classification must transition to a strictly anatomical model, one anchored to the exact physical site where the tumor originates. Cancers that begin inside the TDLU require a distinct name. The researchers propose designating them acinar adenocarcinoma of the breast, or AAB. This clearly separates them from ductal adenocarcinoma of the breast, or DAB, which is a completely distinct malignancy that originates in the major lactiferous ducts. To prove this anatomical origin preoperatively, physicians can use non-invasive imaging biomarkers. Specific features visible on a routine mammogram reliably determine the true starting point of the cancer, offering a structural truth that isolated cellular biopsies simply cannot provide. Aligning our terminology with verifiable imaging evidence ensures that patients receive the correct level of care, preventing systematic overtreatment of contained tumors and tragic undertreatment of aggressive ones. To understand this model, we have to look at the terminal ductal lobular unit itself. Approximately 75% of all breast cancers originate right here. This diagram and tissue samples show a normal TDLU structure. The extralobular terminal duct branches into smaller ductules, or acini. Notice how these acini form a clustered branching structure that closely resembles the budding tip of a plant. This microscopic anatomy translates directly into what a radiologist sees on a macro scale. Look at these specific 1 to 2 millimeter nodular densities circled on these mammographic and ultrasound scans. These distinct clusters correspond exactly to normal TDLUs. Because the healthy TDLU structures are so clearly distinct on standard non-invasive imaging, we have the exact baseline required to track when and how malignant changes occur. The earliest phase, in situ AAB, begins when malignant cells proliferate and produce fluid. This fluid distends the acini, and solid microscopic calcifications crystallize inside. Clinically, this process becomes visible on a mammogram strictly through the specific formations of these microcalcifications. This side-by-side image shows the first major imaging biomarker. Grade 1 in situ AAB presents on mammograms as clusters of powdery cotton ball-like calcifications. The corresponding tissue sample reveals the actual Samoma body-like calcifications formed within the fluid. As the cancer advances to grade 2 in situ AAB, the biomarker shifts. It presents as clustered pleomorphic microcalcifications that look like crushed stone. This chart details the distribution of malignant-type calcifications in a screening population. Powdery calcifications account for 18%, and crushed stone-like calcifications account for 52%. Combined, these two types represent 7 out of 10 malignant calcification cases. These specific calcification shapes are not random artifacts. They are the direct biophysical consequences of a malignancy localized specifically within the TDLU. When the cancer breaks out of the acini and becomes invasive, the architectural distortion of the TDLU creates distinct macroscopic geometric masses. These panels demonstrate the primary imaging biomarker for an invasive AAB, a stellate or spiculated tumor mass. The spiky radiological silhouette in panel A is a 1-to-1 reflection of the physical tissue reality shown in the cross-section of panel B. The secondary imaging biomarker for invasive AAB is a circular or oval-shaped tumor mass. Moving down to panel C and D, we see a clear demonstration of this circular tumor morphology. The convex microlobulated contour visible on the mammogram is identical to the physical boundaries of the underlying tissue section. If a mass under 15 millimeters presents with a strictly stellate or circular shape, it is an invasive AAB. The shape itself dictates the origin, rendering cellular subclassifications secondary. Applying the generic label ductal to a small stellate mass ignores this geometric evidence entirely. By grouping these relatively contained TDLU origin tumors together with true duct origin cancers, the current system heavily skews clinical risk assessment. True ductal adenocarcinoma of the breast, or DAB, operates through a completely different, highly aggressive biological mechanism called neoductogenesis, rapidly penetrating into surrounding healthy tissue. Because of this rapid spread, true DAB carries a significantly poorer prognosis, with a long-term fatality rate of approximately 30%. This is a stark contrast to isolated sub-15 mm AABs, which typically have a good to excellent long-term outcome and are highly controllable. Conventional prognostic factors, including immunohistochemical biomarkers, fail to identify which of these early 1 to 14 mm tumors are actually fatal. Without the architectural context provided by imaging biomarkers, cellular-level tests alone are blind to the lethal structural differences between AAB and DAB. The direct clinical consequence of this nomenclature error is systematic surgical overtreatment for women with isolated early-phase AABs. Conversely, there is an inverse lethal danger. A patient is easily undertreated when a small documented AAB masks a concurrent occult DAB. These mammogram and MRI panels illustrate exactly this kind of complex, multifocal case, where both AAB and DAB co-occur simultaneously within the breast. You can pinpoint 4 small 3 mm AAB foci embedded deep within a much larger high-risk territory of diffuse DAB. Understanding the full, multifocal extent of the disease preoperatively through imaging is the single most critical factor for surgical planning and patient survival. The corrected anatomical mapping model is straightforward. TDLUs produce acinar adenocarcinomas, marked by powdery or crushed stone calcifications, and stellate or circular masses. The major ducts produce ductal adenocarcinomas, marked by casting-type calcifications. Pathologists, radiologists, and oncologists must adopt a unified, anatomically accurate language. Vague cellular resemblance criteria must be replaced by verifiable structural architectural evidence. The entire modern era of early detection relies on our ability to accurately identify and treat these non-palpable AABs. Integrating mammographic tumor features directly into primary diagnosis shifts oncology from statistical guesswork toward precise anatomical prediction.